it's similar to a talk I did do at the last conference. So it's all about macrophage polarization, but I've updated it a lot just because there's a lot of expanding stuff happening there. And then I expanded the end of the talk to talk about what I call the P3 protocol. So a lot of this stuff, if you heard it, again, I don't want to bore you. But I think once you start, it's all research-based, so it is a little bit boring, but it's actually very exciting because what we're finding out, it really validates a lot of the stuff we've talked about this weekend. It validates why we integrate things into our programs. So it's very exciting, and I think also it gives you guys some literature and some research background to say why you do what you do, and especially as we're expanding and adding new things to our repertoire of things. The goal here today is a few things. Understand inflammation. I always used to think inflammation was bad. 10 years ago, inflammation's bad, take the NSAIDs. In sports medicine, that was our standard of care. It's inflamed, give them NSAIDs. And we're starting to really find a lot about inflammation. And over the last, 15 years with prolotherapy, we're like, oh, inflammation's good, but inflammation's bad. So it's really hard to educate our consumer from a marketing perspective on inflammation because we always poo-pooed it and cortisones are bad, etc. So we're going to talk about the truth about inflammation, and it's a polarization. It's a synchronized thing that's going back and forth. It's good and it's bad. So we're going to talk about macrophages because they are the cells that run inflammation. We're going to talk about the good macrophages, the M2s, their positive effect. We're going to go to a lot of detail on the M1s and how M1s can destroy our patients. They make them apathetic, depressed. It rots their joints. And we're also going to go over a lot of evidence-based treatment options that maybe aren't well known, but we have research to say why we do dextrose, why we might add magnesium to a cocktail, why we might do ozone or photomodulation. So lots of really fun stuff. So my question, if you were going to pick one of those patients to treat, which one would you pick? Right? It's like a funny question. It's super obvious. You're going to do, Joe Fitness, because Joe Fitness is motivated. He's going to listen to your advice. He's going to take the supplements. He's going to love his physical therapy, but he's got the protoplasm and the environment to heal and repair. His bro, smoking, bad. He's not sleeping good. He's stressed. He's trying to run his business. The dude's not going to heal. So you can go in there and put all the biologics in, get all cool with MFAT, and you're going to have a very negative outcome. So we have to convert our M2s to those M1s. So it comes down to inflammation. In inflammation, we talk about the macrophage, which is an inflammatory cell. That inflammatory cell has a very critical role in the immune system. But we're finding about macrophages is they can switch personalities. They can go from Dr. Jekyll to Mr. Hyde. They can go to I'm going to break you down and inflame you, chronic pain forever, to life is good and you're healing, it's calm. It repairs our gut, our brain, our tissue. So the question is, can we get more M2s, right? The type of people in the population of those cells that will heal. So if you look at the two types of macrophage, it can be the same cell. We just want to polarize it to an M2. The M1 macrophage is basically pro-inflammatory, releases cytokines that cause inflammation and pain. So the goal is to really have less of those. The problem with pain is the more we have pain, the more it gets centralized into the brain. So that book I wrote back there, that's a book on pain RX it's called, and that book really focuses on centralization of pain. The book that's coming out hopefully in 2025 early is going to be all about these macrophages. So this is going to be in a very long book already, 400 pages, of a lot of detail. And it's going to go into the detail on the dosing, the reasons, the why, the research. This is going to be a high-level talk today looking at the overview, but hopefully somewhat inspiring from that point of view. Now the blue guys, the calming, the Rasta cells, the M2s, they're awesome. They are anti-inflammatory. They release cytokines that stop and resolve inflammation. Through resolving inflammation, they decrease the pain. But the bonus is they induce repair. Everything we've talked about at this conference is about modulating the body to induce repair, right? So that's pretty exciting. We can do that. But we have to figure out how to induce those M2 macrophages. Like I said, the studies are showing that with prolonged pain, for example, the knee is a great example. Knee, we see it every day, bread and butter, chronic pain. If they start having knee pain and arthritis for more than about 3 or 4 months, the pain becomes chronic. The maloo inside the joint becomes an M1 maloo, which means it's inflamed, it's irritated, it's mad, and it starts to rot the cartilage. That eventually spreads to their nerves, to the dorsal root ganglion, which eventually spreads up to the brain. That central sensitization, and arthritic joints have a high risk of central sensitization. So if the patient has had pain more than 3 months, they've got a bad knee, they're getting apathetic, they're centralizing their pain. So just injecting the joint is not going to solve their problem yet. So what happens when we have that M1 dominance, which we definitely do see, is you're going to have a pro-inflammatory state and they're not going to repair. That's why we talk a lot about preparing the soil to plant the seeds. If you don't have the soil cleaned up, get the weeds out, get some fertilizer in there, nothing's going to grow. We have to prepare the patient before we inject them. So what are some of the big influences on why we don't naturally polarize into a healing state? So a lot of that is the chronic injury. The chronic injury is stimulating those nociceptors. The nociceptors get chronically into this stage of firing and pain and inflammation. So we do have to resolve their peripheral pain if we're going to go central, because you have to resolve that influence first before you can put out the fire up here, because this fire is out of control. The biggest thing we see, though, is going to be environmental and lifestyle. So they might have some bad gut health, but also they're eating tacos, they're not sleeping well, they're stressed out, they're smoking, they aren't following the healthy lifestyle. So we'll touch on lifestyle changes, but that is the number one reason that we can't repolarize to a healthy M2 state. So again, the chronic, if we can get more M2s, what do M2s do? M2s are going to reduce the pain, inflammation, and support that tissue healing. So again, you're going to see tons of studies and little references and citations, because this is all really bearing out. And a lot of these is 2022 to 2024, right? This is a lot of new research on these macrophages. So what happens with an injury, right? Say I'm talking up here, I'm getting super excited, but I fall off the stage. I sprain my ankle. It's going to puff up. That's M1. M1 is saying, you are injured, don't get up and don't put pressure on that, because we have to heal you first. So that M1 state is good. It's an alarm state. It's swollen. It's irritated. But we need that to resolve. We need it to go to the M2 state. And so a lot of us that do a lot of prolotherapy, for the past probably 20 years, we've been showing you guys this slide. This is what prolotherapy does. It induces irritation, and then it eventually heals us. The top part of the slide, where the two wedges are kind of changing, that's new. That's actually showing you in mirror what happens with an injury. At first it hurts. 1 to 2 days of pain. That's M1 domination. 5 days to 3 weeks, the pain is resolving, you're starting to heal. At the top, that's the blue, that's the M2 starting to take over. The macrophages are now stopping the pain and inflammation and inducing a healing response. It's exactly what you see when you hurt yourself. It hurts for a while, it sucks, by then I'm putting a little bit of weight on it, okay, I'm walking and it's healing. So we do need to promote the M2 polarization down the road. If not, this is what we get. If we don't polarize to the happy, it's going to be chronic apathy, pain. I tell you what, this is what I see every day. On my original patients, they're a new patient coming in. I see these faces, and I see apathy, and I see loss of hope. With what we're teaching you, you can give hope. You're going to cry with your patients because you're going to change their lives, because you're going to change with apathetic faces to a lot of happy faces. This is a cool slide. It talks about biotensegrity. So really, when we talk about biotensegrity, we tend to say, the elbow affects the wrist, which we're talking about yesterday, that if we're going to help that CMC, we've got to help all of this. That's the end point of biotensegrity. Biotensegrity starts in the mind. It's the mental, it's the spiritual, right? That's going to affect our stress, which affects our adrenal glands, which affects our healing down the road. Then it comes to the cellular level. What am I eating? What am I drinking? What am I doing from the cellular health? Getting my ATP, my mitochondria working. That goes to the central nervous system. We talked about centralized pain. Eventually goes to the gut-brain, connection. The rest is what we talk about with biotensegrity, the ligaments affecting the tendons, affecting the joint, fascia, and spine. So again, but it starts way before there. So if we're not, talking about our patients and counseling them on their mental health to their cellular health, forget about the peripheral stuff. We've got to go as far small and minute, almost spiritual, to get this better. So what about the M1 effects? This is the scary part of the talk. It's going to get dark for a little while because it's going to be very sad. But remember, there's M2 at the end of the talk, which is exciting. So M1 effects, they are going to produce those cytokines. They produce something called reactive oxygenated species, which basically kind of go in and they kind of damage DNA and RNA. When you have damaged proteins, you cannot create healthy proteins. They get overzealous and we create a lot of MMPs. So a macrophage that has a lot of MMPs is like the Pac-Man with big old teeth. It's eating the good cartilage now. Those bad macrophages eat all the good away, right? They're trying to repair, but they're repairing too much. They're eating away the good, which causes more tears and degeneration. And then those MMPs also make a problem with our blood-brain barrier, which allows inflammation to get to the brain. So the other thing, this is interesting, and this is I was up at Caribou again this morning at 6 in the morning, looking at some more research, looking at a couple more articles to throw your way. And what we're finding is that in an osteoarthritic environment, like in a joint, one, it's an M1 state. That means it's inflamed, it's autodigesting, the macrophages are going nuts. It's actually a hypoxic environment, which means there is not enough oxygen. We know that the M2 macrophage likes oxidative phosphorylation, which is a way to make ATP using oxygen. So we need oxygen in our joints. Ozone helps, right? It creates oxygen. It also tends to be a metabolically unstable environment where often there's hypoglycemia. We alluded yesterday that hypoglycemia leads to nerves inflamed, right? Well, joints, if they're hypoxic and glycopenic, they also are very achy. So it leads to the fact that, well, maybe dextrose can have a positive effect on our joints. So that's what I was researching this morning. Is there any data out there on glycopenia or metabolic disturbances in our joints that lead to pain? So we found these studies. So glucose is essential for chondrocyte energy, ATP, and extracellular matrix maintenance. Okay, so glucose is needed for chondrocytes to act normally. Sugar, dextrose, prolotherapy, dextrose around the joint, dextrose around the nerves. Why do we put dextrose in everything? The study confirms the why. 2023, we found that a disruption in glucose metabolism impairs chondrocyte function, contributing to cartilage degradation. Okay, that's why prolotherapy works, because dextrose helps the chondrocyte create ATP, so the chondrocyte can no longer be a M1 screaming macrophage eating things. It can convert to a healing macrophage. So I really do think dextrose polarizes macrophages, which leads to a blocking other stuff too, which I'll show you coming up. So another one, low glucose does produce M1 macrophages that we know. Low glucose levels produce M1 macrophages. So low glucose is a screaming macrophage. M1 macrophage release those pro-inflammatory cytokines that cause cartilage breakdown and degradation. The previous slide, we found out that dextrose is needed for chondrocytes. So add dextrose to everything. It's really simple. What about the studies that are looking at the M1 state and subchondral degenerative changes? So Dr. Desai was talking a lot about the subchondral bone. We can put needles in subchondral bone. We put things subchondraly. Did you know that M1 dominates in a subchondral progressive arthritis? So when you look at the arthritis progression, at first we have what? Synovial inflammation, the joint's not breaking down. But we find in chronic arthritis that M1 macrophage is part of the synovial lining. It's dominating the synovium. We also find that it's in the cartilage, it's in the subchondral bone, and they dominate the central nervous system and the blood-brain barrier. So a study here looking at the synovium. So in the synovium, M1 macrophage perpetuate inflammation, pain, and joint damage. In the cartilage, M1 macrophage stimulate MMPs. Those MMPs auto-digest the cartilage. Okay, 2 studies there. In the subchondral bone, now the arthritis is progressing at stage 2 to 4, bad arthritis. You're getting the cysts and the breakdown. These MMPs, the bad ones, the M1 macrophages, they stimulate osteoclasts. Osteoclasts are breaking down and reabsorbing the bone. Kind of similar to what we were talking about yesterday with CRGP. Maybe they're stimulating each other. M1 macrophages also induce the osteophytes, so the bone spurs and all the bad stuff. In the cartilage, too much MMPs, the macrophages auto-digest and it eats all the good cartilage away, causing cartilage breakdown. In the brain, M1 macrophages cause centralization of pain because they break the blood-brain barrier now. So again, everything's centralizing. That makes sense. We've studied a lot the progression of arthritis is becoming subchondral. Let's put platelets and bone marrow on the subchondral bone. But if you're putting those in a bone that's dominated by bad macrophages, you're fighting yourself. Okay, so we can make life a lot easier. And that's the exciting part coming up. There's a summary of M1 macrophages in the progression of arthritis, starting from the brain to the synovial fluid, the synoviocytes, to the cartilage, to the bone, to the subchondral bone. Each one of those is affected negatively by an M1 dominating state. The M2. Now we're just going to relax and get excited because we've got a lot of fun stuff that we can do on M2s. So M2 macrophages modulate the chronic pain, they resolve inflammation, they induce healing. That's interesting. Well, it's important to know that if they do such good stuff, what are they doing? Okay, how are they affecting things? So this article in 2023 really was looking at the mechanism of how M2 macrophages work. So we're going to touch briefly on each one of those mechanisms because it's important to understand the why, I think. Number one is everybody loves opioids. Well, not really, but we like the effects that opioids give us. So opioids, an M2 macrophage, you can see there up in the yellow number 1, they're releasing opioids. They're releasing opioids that bind to the nerve, the sensory neuron, and say, shut down, chill out, everything's good. So opioids are good if we're not taking them. If the body's making natural opioids, that is good. M2s make natural opioids. That's good for mental health too, because natural opioids like LDN, who does LDN? LDN induces an opioid release naturally from our body, probably by affecting the macrophage. So the second thing that it does, it creates interleukins. Interleukin 10 is secreted. Interleukin 10, you can see the number 2 down there, crosses over, binds to receptor, and it downregulates the pain. It's an anti-inflammatory cytokine. We talked about these SPMs, specialized pro-inflammatory mediators. Now this is where it gets super geeky and exciting. These guys are released, again, from the healthy M2 macrophage. It crosses to the neurocyte, and what does it bind? It binds this GPC receptor. What does that receptor do? Shuts down TRPV1. Okay, we've been talking about TRPV1. Everything's TRPV1. M2 macrophages stops TRPV1. Remember yesterday we found that TRPV1 is responsible for neuropathic pain, nociceptive activation, CGRP, and joint breakdown. So a good macrophage blocks TRPV1. It causes efferocytosis. This is where basically you got an injured neuron. The macrophages can come in and they can auto-digest the debris in the bad nerves tissue and helps to recycle those nerves. So we want a lot of this phagocytosis, engulfing of the bad nerves and basically recycling them. We talk a lot about mitochondria. What's really cool about the stem cells do the same thing, is a good macrophage can come up to the dorsal root ganglion and say, oh my gosh, this is an injury. It actually transfers over a healthy macrophage over to the nerve. Now the nerve has a macrophage. What does the macrophage do? Creates ATP and energy, right? ATP, again, and the other needed for that thing is oxygen and glucose to make ATP. But in this situation, the mitochondria can now become healthy in that injured nerve and create good energy. With good energy, all cellular function can return to normal again. Extracellular vesicles are interesting. Stem cells do this as well, but a healthy macrophage can transfer in this little blob, goes across, attaches to the bad neuron that's screaming, and gives it the ability to create normal protein again by transferring RNA in these little vesicles. So good RNA means that I've got the template to make good healing again and good proteins. That's cool. Then we talked again about the blood-brain barrier and that we need to heal our blood-brain barrier. M2 macrophages can heal the blood-brain barrier and the gut barrier as well, and that leads to decreased centralized pain. Okay, that's great. Well, where are all these M2 macrophages located? They are located everywhere. Here's where they're located. They're located in the brain. They're located in the dorsal ganglion and the spinal cord. So that's centralized pain. They're also located peripherally in the peripheral nervous system, all of our nerves, in our skin, in our soft tissue. Soft tissues include ligaments, tendons, and meniscus. It's located in our joints. We talked about the synovial lining, the subchondral bone, our muscle, our gut, and our lungs. So let's break that down into each one. What I'm going to do as we're breaking them down too is I'm going to throw out to you some treatment options we have for each one of those macrophage locations. So in the brain, we know that M2 is in the brain. This is the good macrophage now. It's the calming. Reduces centralized pain through healing the blood-brain barrier, and it causes neuromodulation. So it kind of, the neuroplasticity in the brain and the pain, it can modulate that pain and alleviate those chronic pain conditions. So what type of injections or procedures do we have that can reach the brain? Well, we can go intrathecal. Okay, sphincter tone. We all don't want to go intrathecal every day. Intrathecal is risky. You can get, you need blood patches, We are doing some more intrathecal stuff right now just because of spinal cord injury patients. There's studies showing that intrathecal injections can help with spinal cord injury. So we're doing it, but we don't love to do it. There are 3 good studies that have been studies showing cortisone in the intrathecal can decrease pain. Some good newer, not to say good, I should say some early clinical trials in stem cells and platelet lysate in the intrathecal space. Now the rest of them, the magnesium, the B12, the curcumin, resveratrol, CBD, and IGF-1, there are more animal studies and emerging studies. So I highlighted the top 3 because if you're going to go there, those are probably the only ones I'd use at this point intrathecally. The good news is we can go super simple with this. We can go intranasally because we know that in the back of the membrane back here, I can snort something up there. It's going to go right to my brain. That's why cocaine, we've all done it. You go, whoa. No, I'm just kidding. I've never touched cocaine. Is this getting recorded? And I haven't actually. I'm now being honest, but I haven't. But we've seen the movies. They just get nuts because it goes immediately to the brain. They're buzzed right away. We can do medications the same way that we all do crack at night, right? We can go in with synapsin. So now synapsin is just a twice a day, intranasal inhaler. What it is a combination of ginseng, okay, a combination of B12 and B3. That combination eventually crosses the brain. B12 is calming, ginseng is calming, it decreases neuroinflammation. So I use a synapsin on all my concussion athletes, my concussion patients, anybody with Parkinson's disease, history of stroke, anything affecting the brain, it works really well. You can also use it on centralization of pain patients because it decreases that centralization of pain in the brain. Oxytocin's been studied also to calm down the pain. It's good with other sexual side effects as well. You can do insulin, which is neuroprotective and improves the memory, and you can snort ketamine. These are lower doses of ketamine that aren't going to have the high effect or the addictive effect. And ketamine has been known to block the NMDA receptor. That's why it's given IV in other ways, because of the way it modulates those receptors. Okay. Ozone can be done intranasally. It just has to be done with good technique because you don't want to inhale the ozone. You want it to just disperse into the nose, let it get absorbed, but you don't want to inhale it because it is a little bit tough on the lungs. The next place that they're found is in the dorsal root ganglion. This is pretty simple and pretty interesting. So again, it's anti-inflammatory. In the dorsal root ganglion, after an injury, these M2 macrophages start to accumulate there to downregulate the centralization effect of pain, reduces the excitability, and decreases that inflammatory pain. Again, we also talked about the transfer of the mitochondria, always good. The treatment options we have for that is, one, we can do perineural injections. And the question, well, how does a perineural injection go central? Well, what we can do with perineural injections, we can do a few things there. We can do like a medial branch block with dextrose. You can do those palpation guided as well because that medial branch comes from where it's deep, but also anastomosis is right between the spinous processes. So during just an intraneural or an injection right between each spinous process, those end tips of the dorsal root ganglion will absorb the sugar. We talked yesterday about those perivessels that have CSF fluid in them. That means the CSF fluid will flow to the dorsal root ganglion, eventually will go centralized, but it's only like a 2-inch space there, so it's going to get absorbed by the peripheral nerve and go to the dorsal root ganglion. You can also do like selective nerve root blocks, which we'll be teaching you guys in February, so come back for February for that one. But you can do a selective nerve root block and go right by the nerve root in the dorsal root ganglion. We can also, even easier, do epidurals. We can do very safe caudal epidurals using dextrose. These are all the things that have been studied in the epidural space to be effective. Epidural steroid injections have been studied for years, but we're finding more recently that they can be toxic and have negative effects, which I'll get to. So we decrease the dose to 0.1. We can do platelet lysate epidurals. We can do dextrose epidurals. These have all been studied. You can also do magnesium epidurals. That's been studied that way, and vitamin B12. You can also do a little flush with ozone. And at the end, if we have questions, I want to, have you done some ozone epidurals, Marty? He hasn't, okay, because actually I want to do this on Tim. So I'm going to start doing these. This is what I wanted to do a few weeks ago so I could have a story for the talk. But we can do ozone. So I'm going to show you what I've been doing, but what I want to do as well. So this is my trifecta most recently, is I'll do a platelet lysate epidural after every low back case. We'll do the platelet lysate epidural. Then my flush now is a 5% dextrose with magnesium and B12. Because they've independently been studied, here's the studies on that stuff. I'm adding it to it and have had no negative effects, and I think it's helping. Eventually, I want to start adding the ozone because that's been studied a lot in the epidural space. I just want to see what the initial reaction is from the patient and see how Tim squeals out. No, you won't be that bad, but I do want to see him in a little bit of pain. So anyways, we're doing the top ones by next time, by February for sure. I'll give you some advice on the ozone epidural. So what about the nociceptor? So we talked about our VP points yesterday, all the nociceptive places of pain. So the Valais points, we need to know those, and we've talked about those yesterday, those areas of pain that are reproduced when you push on them. We talked about yesterday when you compress the nerve for long enough, the blood flow stops, or if it's stretched too long, that you then get the stimulation of the TRPV1 and the negative effects on the tissue. We also have studied that glycopenia, we talked just about that in the joint, but glycopenia around nerves creates pain based on the studies that McIver and Tanlian did. This just shows you, again, on the top, if you have a nerve without glucose, it screams. When you give it the glucose, the nerve shuts down. That's why our nerve treatments, they immediately get off the table and they dance for us. They're feeling great because they have an immediate analgesic effect there. So we can do M2, we can inject those nociceptors. Remember what we found about M2s around the nociceptor, that the SMP blocks TRPV1. So that's why I'm thinking dextrose is having an indirect effect to the macrophage that is inducing an actual blockage of TRPV1, which is what we thought that the dextrose was doing before. So I do think if we figure out that dextrose is stimulating M2s, dextrose is having an indirect block on the TRPV1 receptor as well as a glycopenic effect. So again, the treatment options we have, we can do PIT injections or nerve blocks using dextrose. But there's also a lot of topical treatments for pain that have been studied. Anything from topical dextrose and mannitol to capsaicin, lidocaine patches, topical vitamin D. A lot of us that do pain, we mix vitamin D with our dextrose. And vitamin D has been studied mostly in psoriasis to block the M1 to M2. But psoriasis is an inflammatory condition in the skin, so it should work for pain as well. So it hasn't been directly studied for pain. It's been indirectly studied for psoriasis, but it's an inflammatory problem. We can do other technology-based things like red light therapy. So red light therapy has been shown to do all the things we're looking to do, from M2 polarization to mitochondria, increases the ATP, things we've been talking about, ATP, what glucose does, modulates the TRPV1 receptor. Okay, another way to do that is using light therapy. It also causes stem cell proliferation as well. So all good things can happen when you do when you put light therapy on before or after your treatments. What about M2s in the joint? So into the joint, it helps with arthritis. It helps to remodel the cartilage. It's chondroprotective. So if you have an M2 environment, it's awesome for joint repair. What kind of treatments do we have for the joint? We can do hyaluronic acid injections, prolotherapy, PRP, stem cells, MFAT, and ozone. They're all good. The stem cell and the ozone do have studies on the M2 polarization. I'm suspecting the other ones do that as well. But there's no direct literature saying that's the mechanism of the effect on cartilage. All the others do say it helps regenerate cartilage, but the two that I referenced there do have M2 polarization studies on them. But again, we're assuming that's what's happening with most of them. So prolotherapy, PRP, stem cell therapy directly with M2s, MFAT, ozone again, directly with M2 as far as research goes, but they're all helpful for pain regardless. I just want to do a real quick slide on muscle injury. So with muscle injury, M2s are going to help with muscle repair, fibrosis prevention. All good things when you have a muscle tear. What I want to highlight on the research here is the platelet poor plasma study, because remember we talked about, hey, if you run out of your platelets, use PPP. This study validates why we use PPP with like enthesopathies or little muscle tears in the multifidi, because it shows it helps with muscle repair and less fibrosis. So if you do have those little muscle tears off the multifidi in the back, if you've got a quad strain that's not healing, put some platelet poor plasma in there. You can always mix some platelets as well, but you're validated on why you're using platelet poor plasma. Again, soft tissue. So we're always talking about ligaments and tendons. You can apply that to the skin as well. With soft tissue, M2s help with wound healing. So again, you want a lot of M2 around your open wounds. Also helps with blood vessel formation and enhances and repairs the area. Also shows associated with enhanced healing and collagen production. So we want those good cytokines around our ligaments and tendons as well. So what options do we have? Same stuff we did for the joints. You know, our PRPs, our biologics, prolotherapy. We have our other things like ozone, shockwave, red light therapy. We can do a lot of technology-based things to convert, to heal our areas. No, this is not as much orthopedics, but I just want to throw it in there because I'm doing a case study on this one. So I have a patient who's had chronic COPD. We know that COPD is a M1-dominated state of inflammation and fibrosis of the lungs. So what does M2 do when it's dominating or when it's better in the lungs? It does secrete the good the cytokines again, what improves their breathing. So if we have more M2s, it can improve their breathing, but also prevents fibrosis formation. It breaks down the pulmonary fibrosis. So then I researched, okay, well, I wonder if we could have any effect doing some inhalers with my patient. So I did find some research on that. As far as the biologics go, they found that stem cells, exosomes, nanoparticles, and PRP had a positive effect on that fibrosis and the bad inflammation in the lungs. You can also do anti-inflammatories. There are a ton of inhaled steroids and stuff that's already standard of care for COPD. You can also mix magnesium. It said the study there may help in asthma and COPD. So what I did is I make PRP every day. So I said, I might as well just try this guy. So I said, hey, I'll do it at cost. I'm not going to charge you for this, but I'd love to because he has bad COPD. His oxygen averages to 90%. He's always breathing hard. I said, hey, do you mind just trying this? I said, I'll do it for you. Would you like to do it? Here's the evidence. It seems like it's going to work. Let's do this. So what he did is we did 5 weeks in a row. I think we did one every other week or every other week. He's just getting done with it. And what we did is I made about 5 cc's of PRP, about 4 cc's of platelet lysate. And what I did is I mixed it all together homogeneously with dextrose. So we got about 12 cc's. I did one treatment in the office. So I had him come in, and he did a nebulizer in the office and did about 3 cc's in the office. Then I sent him home with the rest of the products. Then he did one that evening and then one the next morning. I didn't want it to go bad. And then what we've seen so far is just on his serial, just blood, his O2 sats. He averaged 90, now he's averaging 95. So he's going to go back to the VA pretty soon and have a full pulmonary function test done again. He did a baseline one. He's going to repeat it, and we'll just see. I'm assuming it's getting better based on his O2 sats. But again, you can start adding, this type of concept to a lot of things, including the gut. Inflammatory bowel, disrupted gut-brain axis is all going to be associated with a lot of M1s. M2 has been associated to heal the gut-brain barrier, helps to heal inflammatory bowel. So some things you can throw in there, again, are going to be probiotics, omega-3s, healthy lifestyles. Anybody that has the abnormal gut stuff, I put them on L-glutamine and BPC 157. So another way to kind of biohack the gut and induce some healing and integrity of the lining there. So we're over halfway through this one. I know it's a big talk. So do you guys want to stretch or move around, or are you okay to keep going? Everybody's okay? You're not getting too bored? I'm always so concerned. So moving on to biofilms and bacteria. So I think this is pertinent because, again, I'm showing you all the different treatment options and all the things we can add into our toolboxes. And if you look at the evidence on bacteria in osteoarthritis and back pain, it's pretty like shocking in a way. So what we're finding with the research, this is 2016, is studies show bacteria in the synovial fluid and tissue in osteoarthritis. Bacteria can cause chronic inflammation and pain, and it does induce an M1 state. So if anybody has a smoldering infection in their joint, they're going to be M1 state. So we're probably thinking, I don't get a lot of infections in my joints. I don't see a lot of septic joints coming in. We're not talking septic joints. We're talking relatively asymptomatic knees that have a lot of bad arthritis when you look at the research. So if you kind of break that down, here's all the different studies, relevant studies and references looking at bacterial DNA found in the synovial fluid, chronic inflammation and pain with arthritis, and the influence of M1 macrophage polarization of finding bugs in the joint. So let's just break down those studies a little bit. So now I'm going to break them down based on the type of bacteria. The first one they found P. acnes, which is our bacteria usually on the skin. Gram-positive, its role in arthritis is they found it in a lot of the joint tissue, the synovium of the OA patients. And they're finding that bacteria really likes a decreased oxygen environment. So again, we found that the joints are hypoxic, so this bacteria thrives in an anaerobic environment. It stimulates the M1 formation and also biofilms. So we don't want a lot of that. So the clinical implications were that it's very hard to identify these because they're not septic. But targeted antibacterial therapy like with doxycycline would have both a beneficial effect on the bacteria, but also we're going to find some other positive effects of doxy on cartilage coming up. A staphylococcus study showed that they found, again, staph in all the synovial fluid of OA patients, stimulated the M1s, directly degraded the cartilage. Clinical implications is sometimes we need to do something with antibiotics or something that's antibacterial around these bacteria. These studies found that when people had bad gut health, so people with irritable bowel, inflammatory bowel, they had a high propensity to have those same bacteria, like the E. coli, growing in their joints. So again, it stimulates the toll-like receptors, it's pro-inflammatory. So the clinical implications of the study was we need to address gut dysbiosis when we have joint pain. Makes sense. They said, why don't you add probiotics and dietary modifications? Again, another study on streptococcus with gut dysbiosis. They found a lot of MRI showing inflammation, the M1 changes. They found that the gut dysbiosis was seeding the joints, so you've got to treat the gut as well if you're going to try to treat the joints. Consider probiotics and dietary interventions. This was probably the most interesting study. So what they found here is in the synovial fluid of the 3 different types of arthritis, they found high numbers of bacteria, right? So we're always like, I don't have a septic joint. But they found in this study that 79% of rheumatoid patients had mycoplasma growing, 100% of your non-rheumatoid inflammatory arthropathies, and about 80% of the ones we see every day, the chronic OA, had mycoplasma growing. Clinical implications there was we should identify and see if it is in there. If not, and if it is, we should try to treat that inflammation in the joint. This one here showed that after total knee replacements, they took all that extra bone, they cultured it to see what grew. 91% of those total knee patients, which were severe arthritis, 91% had biofilms inside their joint, right? So they were already infected, and they found that on this post-morbid study. They started talking about antibiotic treatments when you started getting these MRIs with Mobic type 1 changes. So they found that by treating the group with antibiotics, they had a 50% reduction in their pain and disability scores after 100 days. So antibiotics were doing something. So then I just did a literature search on doxycycline and arthritis. And this wasn't even looking at doxycycline and an infection. It was looking at the positive effects on doxycycline on your average osteoarthritic knee. Look at all the studies from 1998 to 2022. Sustained benefits in managing OA progression, reduced biomarkers of cartilage degradation in osteoarthritis, reduced inflammatory meters in osteoarthritis cartilage. They all are having positive effect on the cartilage. Okay, a couple of these studies was rheumatoid arthritis, but most of them was your average osteoarthritis. So what about biofilms? So biofilms is basically a bacteria that is kind of clustered together with its buddies that kind of create this extracellular matrix that protects the bacteria from being penetrated by our immune system or by antibiotics. So this is what it looks like. They start to develop this little this biofilm covering. That extracellular matrix basically makes it so antibiotics can't penetrate it. It helps so that our own immune cells, our good macrophages, can't attack and clean it up. And it kind of creates a kind of a stress environment protection from hypoxic environments and glycopenic environments. So it protects it from all the things that we don't want it to. So what we're finding is if we're going to be treating biofilms, we've got to be giving things to the biofilms too that break them up. So we usually use some different enzymes that break up the biofilm such that antibiotics can penetrate. Or if you don't want to use antibiotics, you can use all kinds of other ozone and other things that can penetrate better with the enzymes. So they're finding a lot of biofilms. Again, here's that total knee replacements, 91% had biofilms growing. But we're not just finding biofilms and bacteria in our knees, we're finding it also in our spine patients with chronic low back pain. So these studies show that they found the biofilms in the discs, the end plates, the ligaments, and the facets. Different studies are looking at different things, but they found biofilms and bacteria growing all over the place in low backs. There's some MRI thought that we can detect the M1, the Mobic type 1 changes, that it might not just be inflammation. Those could be biofilms when those show up on our MRIs. You really is hard to diagnose unless you're getting a true tissue biopsy to confirm these. So sometimes you have to empirically think, well, nothing else is working. Maybe I've got bacteria. Treatment options we have for bacteria, we can do antibiotics. Sometimes you want to put those intra-articularly. I've got doxycycline in my office. I can inject that into the joint without the systemic side effects. A lot of patients are concerned about their gut health, and they should be. Although if you look at the studies, the doxycycline is much better than the other antibiotics for inducing, killing off the good bacteria. It will still do that, so if you're ever using these antibiotics like doxy, make sure you're doing probiotics at a different time of day than the antibiotic. But we do have to give the enzymes like the serrapeptase, the nattokinase, the bromelain. Any of those things that break down the extracellular matrix is needed when you're combining with antibiotics because you got to break down the cell wall first, or whatever you're doing is not going to penetrate for those bugs that are protecting themselves. Occasionally, you do have to get a surgical consultation to debride these biofilms, but you might as well try something non-surgically first. So what do we have in our armamentarium that we can use with biofilms? This is talking about IV. So does anybody have an IV department? Great. So if you detect someone has chronic pain, inflammation, arthritis, IVs are a great way to disrupt the biofilm. So things that can disrupt the biofilms, these all have research on them. It's vitamin C. Vitamin C can disrupt the biofilm, reduces inflammation, enhances the immune response, but supports collagen synthesis. So what is scurvy? Scurvy is when your skin falls off because you have no vitamin C. Remember the old days, you got scurvy? You need vitamin C to create collagen. So vitamin C is always in my armamentarium orally and IV. N-acetylcysteine, it's another very common IV ingredient. N-acetylcysteine disrupts the biofilms. Does a lot of other positive things. It promotes glutathione. And you can actually put glutathione in all of, we always do a glutathione flush at the end of our IVs. It promotes M2 modulation as well, which is good. There weren't studies directly on disrupting the biofilm, but I threw it in there because it's very healthy, and it did have the M2 studies. Ozone, this is perfect. Ozone in the joint. We're starting to put ozone in a lot of joints, and I'm going to start putting it into a lot more joints down the road because it does disrupt the biofilm. It promotes the M2 polarization. It also enhances oxygen. We know that joints are hypoxic, which leads to pain and more M1, so O2 leads to more M2, the healthy guy. So different things we can inject. So a lot of us were doing steroids, hopefully more, 15 years ago or so, and we are still doing some steroids, but I'm going to go into the science on steroids real quick. So what about steroids when we put them in the joint? Okay, here's the research on steroids in the joint and taken orally. Nothing really good is happening with the traditional injected 1 cc of steroid. High concentrations causes systemic effects and cartilage damage. If you do more than one or two of them, it's going to cause prolonged cartilage thinning and worsening of the arthritis. If you look at what it does to the cartilage itself, high doses, which is 1 cc, not much, causes chondrocyte apoptosis and necrosis, decreasing the cartilage viability. Again, I can keep on going through these. The summary is cortisone at the normal dose doesn't do anything positive. So again, from a marketing perspective, that gives you guys a really good tool to market against your competition. You got to do it subtly because the average person isn't going to understand, well, why don't we do steroids? But you've got to educate a little bit on that why, because everybody else that you're competing against is doing the traditional 1 cc, and maybe some of you guys are too. Look at this study here. This is the kind of the most interesting study I think that I have on the slide, because it validates. You remember I'm always talking, hey, put 0.1 in there. Why don't you put 0.1 cc of a steroid in your shot? This is why we do that. So the standard dose of steroid, which is 1 cc of Kenalog, for example, 1 cc of Kenalog equals 40 milligrams. So at 40 milligrams, anything over 3 milligrams is detrimental effects on cartilage, right? So anything over 3 milligrams, that's not much. A standard dose of cortisone is 40 milligrams. So you've got to go nanogram, small dosing. But what they found at a super low, like the nanogram or the low milligram doses, so if you take 40 milligrams and dilute that by 0.1 to even like 0.05, mLs of dextrose, beneficial effects at low doses. At low doses, it increases the M2, stimulates chondrocyte activity, promoting cartilage regeneration and repair, decrease the inflammatory markers of the M1. So now you have a reason why you go low. You have a good reason to fight and be strong about why you don't go 1 cc of steroids in your joints and your cartilage. And I am now giving all of my patients a handout that says, hey, here's what steroids do for you, right? So you want to educate them because you want them to come to you, but also you want to save their joints. And everybody else is getting 2 or 3 shots of steroids a year in their spine and in their joints. What about steroids in the spine? Okay, here's another summary. So steroids in the spine, they cause fracture, cartilage breakdown, reduced bone density, which induces the fractures, causes more bone spurs, has systemic side effects, increased infections because it decreases the immune system around that local injection, and causes nerve damage. Wow, doesn't sound good. So this study was epidural steroid study. I love this study too. I reference it every day with my patients with back pain because they did 6,000 patients. Half the patients got no steroid injections. Half of them got your standard 1 cc of steroid. What they found, for every 1 steroid injection, increased the risk of spinal fracture by 1/3. That's for 1 steroid epidural. Whether it's an epidural or a facet block, they're always adding 1 cc. So this is a good reference for you guys to have to say why you don't do the typical epidural. That's why you're doing the dextrose call-up or the sweet coddle epidural with 1 cc of steroid, because 1 cc doesn't cause harm, modulates the M1 to M2. The full dose causes this. So this is interesting too. So this is a study looking at lumbar disc herniations, from even just a herniation to a protrusion to an extrusion. They looked at all these back patients that had all these terrible discs popping out. Even up to a year ago, you know what I did when they came in? Oh, you've got an acute disc herniation with radiculopathy. I'd say, let me put you on a Medrol dose pack. It's going to snuff out the bad inflammation. It's going to make you better. At least we're going to get the pressure off the nerve. What I'm finding with this study, though, this study is from 2022, is we need M2 macrophages to go in to modulate the disc, because an M2 macrophage with a disc, even extrusion, the more surface area exposed, the more the immune system can munch it away and remodel it. What they found here is if you did nothing for a year, these extrusions, they healed themselves. As long as the M2 state, they actually mentioned the M2 state needs to occur for that to happen. So at the end of the study, the clinical implications were consider conservative treatments versus surgery. In this case, they wanted to avoid the surgery in these because spontaneous resolution does happen with conservative treatment if you just can modulate their pain and help them get through that year. They also said that NSAIDs and epidural steroids may impair the M2 macrophage's ability to break down and remodel the disc. So another reason not to give the Medrol dose pack right away or to do the steroid epidural, because you're impairing the body's natural ability to repair and remodel that extruded disc. So the conclusion was they just basically said consider other treatment options. Well, we have a lot of other treatment options like the dextrose collar epidural. That's been studied twice, 2016, 2018. We can do platelet lysate epidurals. That's been studied now twice as well. Centeno first and then Freeman more recently, showing that platelet lysate epidural, that's a platelet epidural that's been cracked open. That can help decrease pain in Centeno's study for 12 months. And then when Freeman redid the study using platelet lysate, he got a 24-month pain response using a platelet lysate epidural. It's pretty awesome. Now, to kind of conclude the talk, if we look at all chronic diseases, if they're inflammatory, are modulated by an M1 dominating state. So if we look at chronic diseases like lupus, these are autoimmune disorders, rheumatoid arthritis, even cardiovascular disease, diabetes, these are dominated. Again, all these studies are showing that they all have too much M1 going on. Chronic neurodegenerative disease, so you're getting your Alzheimer's patients, your Parkinson's disease patients, ALS, it's M1 dominated. We've got to convert to M2. Other diseases like obesity, chronic kidney disease, asthma, COPD, dominated by M1. So again, all around the world, or all around the area here, we can not just affect our joints, but we can affect chronic disease in general by kind of looking at these philosophies here. So the first half of the book was that. The second half of the book, I'm just going to give a high overview of what I've done. I basically started at supplements, to every novel medication, to every peptide, to every hormone, to all the lifestyle changes, to all the injections, and I went through all the research and I ranked them from high efficacy, moderate, or high efficacy, high moderate to moderate efficacy on why we might use some of these different medications. If you look at medications, so here's all the medications that I studied and I found some positive effects. So the top ones I'm using, except for the methotrexate and the TZD, I'm using a lot of metformin, a lot of doxycycline. We're using GLP-1s now on our weight loss center, but we're finding, wow, GLP-1s have a high efficacy for modulating bad inflammation. Low-dose naltrexone, we've been using that for probably 10 years. It has moderate to high efficacy in the studies there to promote that polarization. Interesting enough, statins, azithromycin, hydroxychloroquine, even low-dose aspirin. Now I'm keeping my patients on their low-dose aspirin because it's not going to block their healing at that, but it also is going to polarize to M2. Methylene blue, I'd like to learn more about that as far as IVs, and then ketamine had a moderate effect as well. Is anybody doing any methylene blue IV? Yeah, so I would love to talk to you and you guys more about that because I think that is another thing that if you have an IV department that you should be adding because it is moderate to high efficacy. Everything else that I've shown you is moderate or high efficacy except for low-dose naltrexone, but tell you clinically that is high efficacy. It works very well. So doxycycline is not just for muscle. There's a lot of tendon healing studies on doxycycline as well. So if you're doing someone's Achilles tendon, you want to induce their healing with less side effects and chance of infection after procedure or surgery, you might add some doxycycline to it because it improves the tendon repair. And this is not with surgery. This is just a regular injury. The doxycycline help with the healing. Again, all the cycling studies in arthritis are pretty powerful. Metformin is the next one that I studied a lot. So this came up a few years ago. We're having a knee course here, right? And I had a couple of friends came from Brazil. They're two knee surgeons from Brazil. You're like, yeah, Brazil. Everybody goes with a cool accent, much cooler mind. Everybody goes on metformin. Oh, that's interesting. I just kind of let it pass for a while. And I emailed, why do you put everybody on metformin? He's like, oh, because the macrophage influence it has. Like, oh, the macrophage influence. Then I started reading up. That's when I started getting interested in the macrophage polarization because metformin. Look at all these studies. These are all really recently. The oldest one is 2019, all the way to 2023. Enhances cartilage repair and promotes proliferation, reduces synovial inflammation, inhibits the good chondrocytes, improves clinical outcomes. Everything is very positive for metformin. So if you have that patient, my two are doxycycline and metformin that I do the most, and LDN all the time. But if my gut health, I'm concerned about long-term antibiotics, then I'll put them on metformin. Remember, metformin does decrease CoQ10. So if you put them on metformin, put them on CoQ10 as well. But metformin does have a lot of positive properties for M2. Now supplements, we do a lot of supplements. It's great for your patients and it's great for your business. Here's the one, and I kind of rank them from high, moderate, and they're all kind of high and moderate. So the ones that I highlighted there, the collagen, the turmeric, omega-3s, resveratrol, vitamin D, all those are on our post, what we recommend everybody take. Magnesium now I'm adding to everybody with chronic neuropathic pain because magnesium does a lot of polarization, but it also blocks the CRP receptor as well. Or NMDA receptor. A lot of people get probiotics if they have good gut health, but here's all the supplements that have been studied. Again, the book's going to have dosing and efficacious and studies, tons of studies, but a lot of evidence on why we do what we do, and we're doing this already, but this is kind of the whys behind it. Hormones. I heard you guys had an awesome hormone conference on Thursday. Yeah, that's so exciting, but hormones have all been shown. Here's different hormones that have been associated with aging and arthritis, thyroid, all the sex hormones, the adrenal hormones. The only caveat there is the cortisol. Cortisol with chronic stress, if it's elevated high all the time, does polarize to the M2 state, but the rest, if it's low, needs to be replaced so that our bodies can heal. Just a quick overview and some of the things that they do. Thyroid hormone, again, shifts to the M2, helps with better OA management. Estrogen, testosterone, progesterone are all very similar. They all promote the M2 polarization. They're all going to support pain in different ways. Progesterone is kind of a pain modulator. It's a diuretic, decreases stress around our nerves. So anybody who has carpal tunnel syndrome or nerve compression syndromes, I'll often recommend starting on some oral progesterone at night to decrease. Basically, it's a diuretic, but also has a positive effect on nerve pain. The other two, estrogen and testosterone, you can call those more of an anabolic effect. Kind of promotes more of the cartilage repair from an anabolic perspective. Pregnenolone, DHEA, these are our adrenal hormones, cortisol. Both pregnenolone and DHEA are often low in chronic pain patients, and that's so are the other hormones. And that's because the downregulation of the HPA axis. Chronic pain is a stress. Eventually, their body gets so wiped out that the HPA axis shuts down, which means all hormones go down. So most hormones are off with our chronic pain patients because of the stress of the pain. Peptides, these are fun. We've started doing peptides probably the last 4 or 5 years. I kind of coded these in 2 different ways. One, the top 4 are ones that have been studied to do intraarticular. The bottom ones have been studied subcutaneous, and a couple of them orally taken. So peptides, I think, is something that we'll find a little bit more about in the future and how we're going to blend those with our intraarticular shots to modulate more cartilage repair. So a lot of those we'll be adding pretty soon. Probably more of the BPC 157 will be the obvious one. That's another one for gut health too. It heals the gut. What about different injectables? Here's everything that we've been looking at, the biologics, other things like peptides, ozone, HA, collagen, B12, D, magnesium, NAC, methylene blue. Some homeopathics kind of got some press with prolozone. Those have been looked at and used all over the place with prolozone in the joints. So here's the research on the why, on some of those more supplemental, like the minerals and the vitamins. All the research, intraarticular magnesium, that was used a lot post-knee surgery. And they found that just injecting some magnesium IA after knee surgery decreased the post-op pain. So very safe. That's why I'm adding that to a lot of my shots. Vitamin D has been studied. I've got to figure out the how. I tried it on my mom, and she started screaming after I injected it. So I don't know. It's because I was too high of a dose, but my mom's been my guinea pig a few times. So then I dropped vitamin D for a while. Chondroitin, collagen, NAC, vitamin B12. I do that all the time now with our prolozone and our ozone treatments. Technology-based, we're kind of winding down here. Tons of things with technology. If you look at all that technology and look at the evidence on them, they're pretty good. All of these technologies have been shown to increase M2 polarization. A lot of them help with tissue repair and healing. So anything from shockwave therapy, hyperbaric oxygen, PEMF, low-level light or photobiomodulation in the back there, the red light therapy, cryotherapy, so intense cold, thermotherapy, intense heat. Both of those increase your M2, so your saunas and your polar plunges. Ultrasound's been used a lot in physical therapy, increases M2, TENS units, cold laser. Those last are kind of more physical therapy modalities. But the top is all the biohacking stuff we can do. Why wouldn't you? Why wouldn't you, one, add this onto your practice because it helps your patient? Adding those onto your practice, too, creates a separate revenue source that you don't have to be doing all the time. So it's a very wise thing to add. Some stuff on shockwave. We showed you the photobiomodulation study earlier, how it does everything positive that we're trying to do. What about nutrition? When you look at all the different diets, what do you want to recommend for your patient? If you're coming from the promoting macrophage polarizations, this is the top to the bottom, high efficacy to the bottom ones aren't low efficacy, but the top ones are higher. Mediterranean diet seems to dominate everything from anti-aging to living forever to your blue zones. A whole foods diet is very, very similar. You're eating just healthy whole foods. You're dropping the bad carbohydrates and the bad sugars, a lot of good healthy fats, limiting your processed stuff and chemicals. Vegan did pretty well. Vegan is more difficult maybe to sustain, and they had some micronutrient vitamin B12 deficiency, so you've got to have a smart vegan diet because a lot of vegans overcarb it. Intermittent fasting scored really high, and it's easy to add to anything that you're doing. The ketogenic diet I really don't promote as much because people don't know how to do healthy keto. They just do a lot of saturated fats, and about 20% of people on ketogenic diets actually get elevation in their cardiovascular risk factors. So be smart with keto because there's really smart ways to do keto, but it's very difficult to do wisely. So I usually recommend the top 2. We call it a Reju for Life. Rejuve for Life is, again, is our way to market being different in our community and how we're better than everybody else. But we recommend Rejuve for Life, which means I send everybody home with my Rejuve University that I talked about earlier. That means they get access to a very smart meal plan. It's basically a whole foods meal plan that's been spun a little bit just to be super cool, to make us different. Again, you're talking about your niche. You've got to be different from the competition. So ours is a whole foods diet, very similar to Mediterranean. We also have some vegan options. We have some anti-inflammatory options. And functional medicine decides a little bit more based on what the problem is there. But we do have options on lifestyle. Looking at lifestyle, here's the top things that were shown to be helpful was exercise, sleep, stress management, smoking cessation, and having friends, just hanging out. All that stuff has been shown to be really good. So to end it, I just want to summarize it in how do you market this? This is overwhelming. How do I take this and simplify it and then present this to my patients, right? So I thought, I got to be simple. Cool things are in threes, right? Everything comes in three. When you market things, if you have 3 things on a page, it's perfect. 2 things is a little bit off kilter. 4 things is overwhelming. So 3 things on a page is how you want to present this. So I kind of dumbed it down. Okay, how simple can I get? Really simple logos, really simple, words. And I came down to this. We want to do 3 things. We want to prepare the soil. That means we want to kind of get everything cleaned up, get them ready for planting, make sure that when we plant, it's going to heal. So we've got some work to do before we plant. The planting is your regenerative injections. That can be your prolotherapy, your PRP, your MFAT, anything you do to plant those seeds. And then we want to proliferate. We want to make sure that we're proliferate. The proliferation word was perfect because it's like prolotherapy. There's a proliferative phase in healing, right? We were already talking these terms. But after we plant those seeds, we need to proliferate the growth. The prepare and the proliferate phase are really similar. We're looking at their cell health. So cell health is, are they eating healthy, their lifestyle, are they doing the right supplements, have they seen functional medicine, are they meditating, are they praying? That's your cell health. Functional movement is your physical therapy. It's your personal trainer. It's your exercise physiologist. It's moving right, being strong in all the right places. It's the biomechanics of movement. That's functional movement. The articulation is why they're coming to see you. It's the pain in their joint. It's everything hurts. I'm limping. I've got arthritis on my x-ray. I want a second opinion. Is there anything else you can do? The nerve health is all the positive things we're learning this weekend on how nerves modulate pain. So everybody that comes to my office, in fact, we have a take-in form. Our plan is planned around the CFAN model. So when I discharge somebody from an initial office visit, I send them home with some cell health advice. So it's basically my functional medicine consult, weight loss supplements. My functional movement is I send them to physical therapy or a personal trainer. I just say, hey, in general, start moving more. I always talk about the few things I'm going to do on their joint. Let's get you prepped up with some calming down shots. Let's get that joint, just like I was doing with Eric, let's get that joint feeling better. And then I always talk about the nerves that are contributing to the pain. So my plan is always based on CFAN. And then so does that kind of make sense? And then the post procedure is reflecting the CFAN, which more detail. It keeps them coming back to your office. It gives them a plan for success in the future, and it keeps you in front of them for a long period of time. So again, the P1, you gotta prepare that soil for growth, get the weeds out, get it plowed, get it ready. Longer version you guys can read through is exactly what I just talked about. It's talking about all the technology that you're going to do beforehand. It talks about all the technology you can do afterwards. So part of the articulation in the cell health is including the technology like your ozone, your red lights, your shock wave. Some of that stuff you want to do before, you definitely want to continue it after. You send them home and sell them a red light unit. You guys are making the markup on that. It's a smart thing to add because it's benefiting your bottom line, but it's benefiting the patient as well. So again, what about the planting phase? So a lot of the questions beginning is, okay, I'm going to plant. You've been coming to our courses. You're learning amazing technique. The question is, well, what do I use? The technique you're learning at these courses, the technique we're learning today is the technique we'll be doing 20 years from now. So the skills you're learning now, the skills you're learning in February, the skills you're learning next spring because you're coming back, it's going to be the skills that are going to last you forever because our anatomy is not going to change much. We're not going to turn to birds in the next 100 years, right? We're going to stay human for a little bit longer. So we have options. Now, these options will continue to change. So these lectures will change as technology changes us. But right now, we've got a limited amount of things we can plant. The big 3 biologics right now are PRP, bone marrow concentrate, and MFAT. So the question is, well, which one do I use and what's the best thing to plant? We've talked about this a little bit, but I want to give you some research behind the why and how you combine and why you use some of this stuff. So when you think about PRP, you should think about PRP as a fertilizer. No matter what you add fertilizer to, it's going to grow better, it's going to be healthier, you're going to get rid of some of the weeds, it's going to be good. So the PRP has been shown to enhance proliferation, differentiation of the stem cells. So when you do a stem cell, you should always add the fertilizer to it. It's going to have growth factors, and it's going to promote anti-inflammatory cytokines. It's an M2 polarizer. Facilitates that polarization. What about the bone marrow? So BMAC's good. The BMAC itself is the cell that can differentiate into multiple tissues. It can differentiate into tendon, to bone, to cartilage, all the things we're looking at to form. In fact, the BMAC is a little bit better than the MFAT at having more of a multipotent proliferation ability. It can turn into more things. So it's a little more multipotent type of a stem cell, but it doesn't mean MFAT's not good. So my analogy there is the BMAC is your seed. You're planting a seed that can grow into something, but seeds need fertilizer, so you always combine BMAC with your PRP. It also promotes the good polarization. So the new kid on the block is the MFAT. So MFAT has got multiple things in there. It's the soil. It's structural. It's the environment. It also has not just the structure, but it has the seeds implanted in it already. It's also very viscous and strong. It's also the scaffolding that the soil and the seeds can grow off of. So it's got about three things in there. So it's the soil. It's that natural scaffolding that you need for tissue repair. It has the seeds in it, just like the bone marrow has the seeds in it. It's got the stem cells that can grow into other things. And it has the structure. It's got a lot of three-dimensional structure and an extracellular matrix that gives it some bulk to fill in the stuff. So the seeds in the soil and the structure are all in the MFAT. So the question is, well, okay, I'm still a little bit confused. I see that the BMAC and the MFAT are very similar. Which one do I use and why? So if you looked at the pros and cons, is the BMAC is highly regenerative potential. It has a little bit better ability to form into multiple tissues, but not much. It's well researched. There's a lot more research on BMAC from its efficacy and how there's just more studies. It doesn't mean the MFAT's there. It just hasn't been there long enough. Suitable for several kind of conditions. The harvesting of BMAC is pretty straightforward, and the MFAT's pretty straightforward too, but the BMAC is just right in and out. Although they say the MFAT's actually safer because you're not penetrating bones. So there is I think technically once you've done a few of them, they're both going to be very similar. Minimally invasive, you get a high concentration of stem cells. When it comes to the MFAT, again, they say it's minimally more, less invasive. You're not going quite as deep. You just have to have good technique and know where you're going. It has a very high concentration of cells, even higher than the BMAC. And that concentration, that high cellular, stays high as we age. So the caveat there is going to be probably an age dependent or what you feel comfortable doing. If it's going to be an older patient over 65, I'll probably start going more to MFAT. If it's a young population and it's easy to get, and you can go for the BMAC. If it's a really thin athlete, they don't have a lot of fat to suck out anyway, so you might be going more into the BMAC. So it's kind of a way to kind of look at that and differentiate, well, which tissue do I use? What about ozone therapy? I just throw a couple slides here on ozone because I think it's kind of neat. There is a lot of research now kind of showing how you combine ozone with other things, but the timing is very important in how we do that. So ozone has a lot of positive effects on M2. It enhances the oxygenation. We know that tissue needs oxygen. It is antimicrobial. So all the stuff we talked about, ozone can be helpful for, right? It blocks the bacteria, blocks the bioform, induces oxygenation, and it decreases inflammation, promoting healing. What about if we combine this stuff with things? So this is cool because there is research now coming out on combining these things. So when we combine PRP with our ozone, it has a positive effect, enhances the release of our growth factors, increases the regenerative potential of our PRP. But when timed properly, and then we're going to get into this, ozone enhances regenerative capabilities. So what they found with this is you had to do the ozone first. You have to give it at least 20 minutes for the O3 to dissociate into O2. If you did like the ozone right away and the PRP right away, the O3 is a little toxic to the cells and it started to kill the PRP or the platelet cells down. So if you're going to combine it, do the ozone first, let it dissociate into oxygen, and then flush it with your PRP. They found the same thing with the stem cells. So the stem cells, when combined with ozone, maintain better viability, have better regenerative capabilities. That's awesome. But just make sure that you give the ozone 20 minutes so those reactive oxygen species can dissipate. That happens very quickly, and then inject it. So that we have a minimal damage to the stem cells themselves. The O3 is a little too powerful right around the stem cell. It's going to kill the cell. So you got to let it turn to oxygen, then it enhances the cell. Does that make sense? It's only 20 minutes. That's all you got to wait. Go see another patient. Come on back. Subchondral bone, we'll just touch base on that real quick. We know that subchondral bone is part of the pathology of arthritis, that we're starting to get bone marrow edema, cyst formations. and breakdown of our cartilage. We did see a direct correlation with the M1s being dominating in the subchondral bone. What we're finding down from the evidence base is that we may want to start doing something in the subchondral bone to decrease this inflammation, the microfracturing, and the cysts that are going on. So bone marrow edema is basically increased vascularization, a lot of inflammatory cells. M1 contributes to the pain and further degradation because the cartilage we're finding heals from the inside to the outside, or inside to the outside, whichever way you're going. The bone marrow edema does cause a lot of pain because it's swelling, it's inflamed, it causes a lot of pain inside the joint, and that can be very painful. So it causes more pain with arthritis. Causes more degradation. We talked about that. You start getting these cyst formations. That's causing from the cartilage's breakdown. You get fluid intrusion into these cysts, and it further weakens the integrity of that cartilage. You start getting a lot of collapse of the bone. You start getting altered biomechanics. They start getting really valgus, varus. It starts throwing off their whole body. So we want to prevent if we can. But if it does happen, and we start getting our X-rays and MRIs showing moderate to advanced changes, then you might want to start putting some stuff into the bone. So here's a picture of us a few weeks ago putting our trocar in the subchondral bone. It hurts a little bit more, so use nitric oxide and pre-medicate them. But the studies are showing that when you combine IO with IA, this is how you prevent the joint replacement. So it's a much higher propensity of decreasing the need for joint replacements when you combine the two. So, a couple years ago, all we're doing was IAs. Now we're starting to combine the IOs. So I think at our knee course, we'll definitely do this really simple ultrasound, and we can confirm it with fluoro course for you guys. There's the study showing you combine them, you get enhanced regenerative potential. You are going to optimize your outcomes, get better results, less total joint replacements, good relief of pain. So in summary, we want to have the toolbox to convert our M1s to M2. We can use novel medications that have high efficacy, have been studied to be safe. There's a lot of supplements that make sense to add to your armamentarium. There's intra-articular injectables, which we've kind of looked at. There's technology to add. We always want to educate on lifestyle, right? And then you want to have a very succinct, somewhat simple approach to educate your patient on this complex thing. And I just call it P3. So again, we have to be innovative. So that means this is going to be changing. We have to be innovative. We have to be outside the box a little bit for our patients. We have to be their advocates. We have to keep on looking at the research, so it kind of guides us where we're going to go. All of us can't be in silos anymore. We talked about silos yesterday. You have to be outside the box. You have to start integrating different solutions into your practice. When you diversify a practice, your life is so much easier because you can be the guy doing this. Everybody else is doing the rest of the stuff, and you can just do what you love to do. But you have to be diversified. You're going to be working weekends. You're going to be filling your noon hours with patients. You're going to be overworked and overstressed. And you need to do the last one. The biggest one is to continue to be educated. So continue to come to see us, continue to go places to get educated because you're only as good as your skill set. So our goal, like we've said before, is to continue to deliver you guys the high-end skill sets to deliver what you want to your patients. And the truth is this is just the tip of the iceberg, that M1 macrophage iceberg. I think as we start to vet out the research, we're going to have better protocols. How do we combine all this technology in this research? How do we time that? What else can we combine to our injections to enhance the stem cells? Is it the magnesium? Is it the dextrose? There's a lot of stuff that we'll vet out here. But all I can say is it's super exciting.